Upon your kind permission, we will announce our today's event as opened. And I would like to pass a word to the director of Dermatovenerology Cosmetology Institute and Deputy Minister of Healthcare of the Republic of Uzbekistan, Professor Sabirov. Good afternoon, dear colleagues. So we are having our conference online. It is my pleasure to welcome all of you at today's conference, Contemporary Trends in Epidemiology, Diagnostics and Treatment of Melanoma. I'm very happy to welcome all of you here, and I'm very happy that the organizers of today's events find opportunities for us to have this event here online, and for us to be able to exchange our experience between the doctors of different specialty, for us to be able also to exchange our experience and to boost our professional skills and knowledge. Contemporary healthcare of Uzbekistan undergoes a substantial reforms, as well as, which are aimed at increasing the quality of life and which are directly linked to improving the healthcare services. I do hope that here you will be able, in the framework of this conference, to exchange your experience in the field of combating melanoma, treatment of it, and I hope that you will be able to discuss the key features of these issues for our doctors, and also to reduce mortality rates and rates of morbidity. I'm sure that all of you will be discussing the issues related to melanoma based on your long year experience, and I do hope that this conference will embrace the wide range of doctors with information on contemporary international trends on using healthcare technologies, innovative healthcare to increase good results, to boost good results in fighting melanoma. And all of us are striving to increase good results in the healthcare, and we will also be able to evaluate the results of developments in this area. And the purpose of our conference and shows also the readiness of our professionals from different countries to boost cooperation in this area, to be able to achieve positive results and progress. And I would like especially note that cooperation between our specialists, different countries, and opportunities to use international experience will be a good platform for us to develop our healthcare further and improve people's life, which the healthcare always aims at. And also we do hope that our fruitful interaction will will be a basis for our bilateral cooperation and multilateral cooperation here, and you will be able to find interesting and innovative information for all of us. And I'm absolutely sure that such a conference and cooperations in such a format will be an important stage for development of healthcare and cooperation in our country in the field of healthcare, because in our country last year we have identified 998 cases of melanoma. We are identifying it, and we are the country of 4th or 5th grade in the area of melanoma, but in the domain of melanoma. But anyway, it shows that, you know, it can be a dark brown melanoma, it can be other melanoma, but it means still that we can easily identify it. And here I do hope you wish you solid health, prosperity, and successes in your work. Thank you, sir, for your welcoming speech. And now I would like to pass the word to Director of Republican Specialized Scientific, Practical, and Medical Center of Oncology and Radiology, Mr. Tilashaykhov, Professor, Chairman of Uzbekistan Oncologists Association. Please, sir. Good afternoon, dear friends, dear colleagues. I'm very glad to see all of you here offline, online, and I do hope that there will be a chances for us to see each other. Scientists are hosting the events, and you know, there are, of course, situations that due to the pandemic, we are changing our formats because we are shifting now to online, but still it opened us new opportunities to exchange our experience all across the world, and we are able to report on significant research results with no disturbance to daily practice, so we can have these kind of events even more often. And I would like to welcome all of you, not only on my own behalf, but also on the behalf of the Center of Oncology, on the behalf of 156 skilled specialists which are employed under our institute, and we are embracing over 700 oncologists all across the country, and we are working on the field, all the fields of oncology, and now working with concentrating our efforts in the framework of today's conference on epidemiology, diagnostics, and treatment of melanoma is also very important. Melanoma diagnostics treatment is an acute issue for oncologists and dermatologists around the world, so today's event is surely important. Noteworthy early identification of oncology pathology improves patient quality of life as well as treatment outcomes, reduces mortality, and increases survival rates. Thus, we have to make an effort to upgrade knowledge of both specialists and physicians, since the fate of patient depends on skills of a doctor he addressed first. I would like to emphasize on brilliant company of today's speakers and structured agenda of our conference. Let me express my highest appreciation to all the speakers who agreed to participate at the conference which was organized. This event will surely pave the way for cooperation between our countries. And, you know, actually, 15, 20 years ago, of course, we had a lot of medicines, but now, within these 2 decades, we are having a lot of innovative drugs and methods of treatment, which we are showing good results. I do hope that it will be a very useful for us also to exchange experience here, because, you know, even in our agenda of our today's event, it is clearly stated there will be innovative methods which will be highlighted here. We will be, you know, embracing reports from Mr. Chakrabarti, from Mr. Shankar, from Mr. Utyashev and Mr. Danka Kostadinov. And of course, I have even read a couple of the information provided by them, and you know, I'm very sure that this information will be useful for all of us in fighting with such pathology as melanoma. And also, I would like to know that such events play an important role in joining efforts of oncologists and dermatologists and venerologists from different countries of the world in further development and improvement of oncology-related medical services all around the world. And because, you know, we are also training the specialists and they're doing their scientific research in these focused areas. So I do hope that today's conference will be useful in boosting also cooperation between our countries and especially for oncology domain in all of our countries. Once again, I would like to express my sincere gratitude to our organizers, and I would like to wish all of the participants of today's event fruitful meeting, and of course to have it in a good condition, in a good mood. Thank you for your attention. Yes, thank you so much, sir, for your speech, and we would like to pass the word to the Vice Principal of Tashkent State Stomatology Institute. Please, Mr. Rustam Asimjanovich, the word passes to you. The floor is yours. Dear colleagues, good afternoon. It is my big pleasure on the behalf of Tashkent State Stomatology Dentistry Institute to welcome all of conference participants of this conference, which is dedicated to such pathology as melanoma. After hearing the speeches of our professors, Mr. Sabirov and Mr. Tilashaykhov, I just would like to express my sincere gratitude to our organizers and to wish all the participants fruitful work and, of course, good mood while having this conference. Dear colleagues, please also be advised that Ms. Jamila Pulatova is hosting our conference. She is not only just a beautiful lady, but she is also very intelligent lady. She is a General Secretary of Oncologist Association of Uzbekistan, and she is head of musculoskeletal tumors department of Republican Scientific Practical Medical Center of Oncology and Radiology, and she is professor, PhD in medical sciences, and you know, actually starting from your from the beginning of your career as a doctor, she works with skeletal pathologies, and she also embraces melanoma. So please, Miss Jamila, the floor is yours, please. And dear colleagues, it is my big pleasure to welcome you today at today's conference dedicated to contemporary trends in epidemiology, diagnostics, and treatment of melanoma. Actually, melanoma was initially one of the rarest pathologies in the world, but now, due to worsening of ecological environmental conditions and ozone gaps appearing in our atmosphere, we are having growing numbers of new cases of melanoma all across the world. And due to aggressive path of melanoma and negative forecast, it is a very challenging task for our doctors. And of course, here we also must be able to identify the mutations and early diagnostics. Due to this, of course, we have achieved a special certain progress in fighting melanoma, and molecular biology is also helping to a significant extent to this area. We also would like to state that our doctors must be aware not only about the melanoma itself, but also about the impact of the therapeutic agents which we will be using while treatment. This was the reason why we have actually selected the topic of today's conference, and I would like to wish all of you successes once again, and hopefully we would like to commence the main part of today's conference. Mr. Alisher, where are you, please?
Dear colleagues, let's start the main part of the conference. Before starting the conference, let me inform you that you can ask questions in the chat after each presentation. You can also use the simultaneous interpretation function by clicking the interpretation button at the bottom of the screen. The first report focuses on potential targets for melanoma therapy in mouse models. The speaker is Dr. Abhijit Chakraborty, outstanding basic scientist from Baylor College of London, USA. He made his PhD thesis in cancer genetics. He is executive editor of Indian Journal of Social, Preventive and Rehabilitation Oncology and the member of editorial board of high-level journals. Nowadays, he works in Baylor College of London Medicine in surgical department. Dr. Chakraborty, you can start your presentation.
Yeah, thank you. Thank you, the organizers, especially Alisher Karsal. So myself, Abhijit Chakraborty, I'm working in the Baylor College of Medicine, USA at Department of Surgery. So I'm here today to discuss about how the basic science develop the diagnostic and therapeutic marker as well as treatment for melanoma. So the melanoma basically originated in the pigment producing melanocytes in the basal layer of cell epidermis. This is especially caused by the unpaired DNA damage occur in the melanocytes, which trigger different kind of mutations in multiple regions. And it's mostly black or brown in color, but sometimes it may be pink, purple, or blue or white. So it's generally happen due to the exposure of UV light and different genetic predispositions. So in 1% died in melanoma in every hours, and 30% of all melanoma found in the male and arise on the back. The incidence of melanoma is rising day by day. So as per the estimation of American Cancer Society in 2021, estimated new cases, 62,000 of new estimated cases will be found in the male, and in case of female, it will be near about 43%. Among them, the 5,000 for male and 2,500 for female will be die in 2021. So melanoma can happen in various parts of the body. So the basically this is like 4 stages. The maximum T4 stage is 2 to 4 millimeter long, and the survival rate for the distance metastasis is only 22.5%. So the basic concept of melanoma is start from the asymmetric, that one side different from other. This is the very benign form, and then the border is irregular to notch and blur, and then it comes to color, which are mixed, and then diameter increase, which larger than 6 millimeter. So the molecular biology behind the melanoma is the significantly have more sequence variation per megabase of DNA. For example, a melanoma have 15 times more mutations per megabase of DNA than any other type of cancer DNA mutations. Mutations, especially cytosine or converted to thymine in DNA due to the UV radiations, and other kind of mutation is found like BRAF, RAS, and c-KIT. So from the beginning time to nowadays, different kind of treatment strategy like developing day by the scientists and the researcher. Nowadays, the most common therapy we can see is immunotherapies. So this is the most promising till now, but till now there is no particular therapy which can totally cure the disease. So there is a need to develop some kind of new drug or therapeutic drug or potential marker which can inhibit this disease and cure the disease. So some FDA-approved immunotherapeutic strategies of melanoma is available. Like some of them are checkpoint inhibitor, some of them are cytokine inhibitor, some viruses also which can inhibit melanoma, and some other vaccines which are available for the melanoma treatment. So as the different potential treatment not available till now, so we are looking for some other promising treatment. So we focus on some protein that's name is timeless. This is a circadian clock regulator. This protein is important because of the function of its DNA replication and DNA damage repair. And this protein also binds with another protein that is called TPin. This TPin also help timeless protein to repair the DNA damage in different conditions. So we thought there must be play some role in the melanoma. So why this protein are important? Because this protein complex protects from the UV damage, which is the essential cause of melanoma. And this protein complex also stabilize DNA replication fork, and also it's maintain the telomere length. So what we did first, we just took some patient sample near about 461 patient sample and 558 normal sample, and checked this protein level expression. And in both cases, in both of the protein cases, during the patient tumor, we found these two protein expressed very high, and the survival rate of this patient whoever express this kind of proteins, that survival rate is very low. Then we collect some tissue from the patient and stain it with immunohistochemistry, and also get that these two protein express very high in the patient compared to the normal control. Then we took different cell lines. These cell lines generated from patient cells. So this is directly characterized through the patient. So we compare this protein expression in these cell lines. We have different kind of cell lines. We compare this to control, and we got this protein expression going high. So there should be some, this protein complex should play some role in development of this disease. So then we choose some highly metastatic patient cell line sample and knock down these two protein. So compared to the normal expression level of this protein, and other two is this SH1 and SH2, means we knock down these two genes of this, which genes express this protein. And we found that if we knock down in only one protein, like TIM, the another protein is also going down. When we knock down the second protein, another protein also going down. So this protein work as a complex, not individually. Then we check the cell growth of these patient cells after knockdown these two protein, and we got that compared to normal control, when we knock down these cells, the cancer cell growing, cancer cell proliferation goes stop. This is another experiment we also did. Here it clearly you can find that compared to normal, when we knock down these genes, the cell proliferation going down. So then we want to know what is the mechanism behind it. So when we compare with the normal control and the knockdown cells, patient cell line, we found that downregulation of these two proteins leads to apoptosis of melanoma cell. That means when you knock down these proteins or genes, the cancer cell going to apoptosis and died. So when these proteins is present, it repair all the DNA. But when this protein is absent to the cell, its DNA damage happened, and due to this DNA damage, the cells become died. So then we think that if this protein express high in the patient samples, and also when we knock down these two protein genes, the cell proliferation going down, then there should be some importance to developing the disease or tumor for this protein. So we knock down these cells and we inserted these cells to the mice. And you can see when the cells is present with this gene in the mice, the tumor grow very fast and it's the size growing very fast. But when these two genes are absent, this tumor going down. This is for the timeless. And another protein, when we check that knockdown, that in the compared to normal, this another protein, the tumor going down, the tumor growth going down. So we confirm that this protein, when these two protein is absent, the tumor size and the tumor cell proliferation going down. That means this protein can be a very good target for diagnostic and prognostic marker, as well as the treatment strategy of melanoma. Then we want to know what is the structure of this protein complex. So this is our predicted structure of timeless protein, and this one is the predicted structure of tipin protein. So we overexpress in a cell these two proteins together and try to isolate and purify it. So we overexpress these two proteins together and into the cell and pull down this protein complex and purify it in chromatography. Then we confirm this by Western blot that these two protein is present with our purified product. Then we undergo the cryo-electron microscopy to know the structure. What is the complex structure of this protein? So these are the image of negative staining, and for the negative staining, we find this kind of structure, which is like 20 Armstrong structure. So these are the different software analysis. Then we go to the cryo-electron microscopy main staining, and these are we collected near about 200,000 particles for that protein complex, and among them we choose 43,717 particles to know the structure of this protein complex. And finally we got near about 7 Armstrong structure. This big part is the time protein and this small part is the tipin protein. So this complex, and now we are know the structure. We are now working on to know the details of the structure. So we are now checking near about 500,000 different kind of drugs which can interact with that protein complex, so that we can inhibit this protein within the cells, and then it can control the melanoma. So we are sure we will have soon a therapeutic and diagnostic target marker of timeless and tipin, and we can control the disease with inhibiting this protein complex. So now our study is under trial, and also we are developing the drug to inhibit this protein complex so that it can be a future promising therapy by targeting this protein complex. So this part of our study is already published in like last year, and other part like the ligand and the drug development is undergoing till now, and from probably by within 2-3 months we'll start the clinical trials on the patients which drug is targeting of this protein complex, and it will be a future prognostic marker also. We can use as a prognostic marker also. I thank you for University of Minnesota and Mayo Clinic for this work, and thank you, Alyssa.
Thank you very much for your very informative presentation. And the next lecture is dedicated to the epidemiology and prevention of melanoma, presented by Dr. Abhishek Shankar, who is an assistant professor in the Department of the Radiation Oncology at Lady Hardinge Medical College and SSK Hospital, Delhi, India. He has worked at All India Institute of Medical Science, Delhi, from 2012 to 2019 in different capacities. He is an NCI Cancer Prevention Fellow and recipient of many national and international awards. He is a member of and the chair of many national and international committees. Dear Dr. Shankar, you can start your presentation now.
Okay, thank you. So thank you, Alyssa, and thank you for inviting me for this conference. And although I am frankly speaking, we are used to talk on breast cancer, cervical cancer, colorectal cancer, and it is a very new experience for me to talk on something which I have never talked before, melanoma, skin cancer. Incidences are very less in India, so it's a kind of rare cancer in India. So I'm Dr. Abhishek, as already introduced by Alyssa. So coming to the point, I have nothing to disclose for this presentation, either financially or any financial interest or affiliation with any organization related to commercial products or services to be discussed at this program. So when you talk about prevention, screening, which is the most important tool, or you can, defense for cancer care, when we talk about the low and middle income countries. So what we see, it's all about perspectivism. We are very much, talking about fancy things like immunotherapy in the skin cancer. So immunotherapy has really glamorized the, treatment paradigm of skin cancer. But probably we need to talk about the relativism, and apart from the location, we need to talk about the context. So context is what we need to contextualize the community where we live in and the people live in. So apart from talking about immunotherapy, it will be a great exercise to talk about prevention and a screening modality for a cancer where prevention and screening plays an important role to diagnose it early. And if you diagnose it early, it is always said you have to minimize your resources in the lesser amount, and you can have a better, survival ideas, and you can minimize the mortality and morbidity related to cancer. So when you ask any oncologist or any physician, do you think cancer prevention and screening are important in cancer care, Indian context or any other context? Probably most of the people will say, yes, it is most important part of cancer care. But the next question, when you ask if it is correct, then how much time do you give to such efforts in your daily practice? And probably you will be very much disappointed with the answer you get from the people, because we think that this is important, but when it comes to devote time and giving something for the society and to make them aware, probably we are very busy with the patient who are on chemotherapy, radiotherapy. So it is the non-glamorous part of cancer care which nobody wants to talk about. So this is very, very important slide. When you want to understand the most important socio-cultural determinants of cancer, till today, we all have an individual-oriented approach towards the health hazards, and we hardly talk about, environmental, education, nutrition, which is a very important socio-cultural determinants for cancer and any other disease. So if you really want to make a great difference in the cancer care, in LMICs, we need to come up with the community or population-based strategies to have a concentrated or sustained social policy. And when I say social policy, probably it will help us to achieve the social justice as far as the cancer care is concerned. So why we should talk about prevention and screening in skin cancer? So patient continue to be diagnosed with a thicker primary lesion in a skin cancer, and everyone knows when the patient comes with a thicker primary lesion, it has an increased risk of metastasis and related death. So most early detectable cancer like colorectal, breast, cervical, prostate has demonstrated sustainable decline in mortality over 3 decades because of an effective screening modality and more of general awareness about signs and symptoms of different kind of cancer. So accessibility of skin for both self and the physical examination, which can identify the greater risk of developing or dying from the disease, should follow the concept of targeted melanoma screening. That means you need to target the screening of the people who are having the risk or who are having the family history, nearby. So these are the risk factors. Although there is still a significant need of effectively implement preventive steps in countries that has not adopted the guideline in line with the most recent data. So we think it is important, but most of the countries, they don't have the guideline, and there are continuous change as far as the guideline is concerned based on the recent data. So primary prevention, what is primary prevention? This is the one form of prevention which is divided into 2 parts. First part is the education, which you can make people aware about the signs and symptoms, about the protection, and they can adopt it. And second part is chemoprophylaxis, which is either vaccine or some drugs which is given to primary preventive. Okay, so reducing the rate of sunburn. Everybody knows sunburn is a very important issue. So you need to avoid it during the peak UV radiation and adoption of protective measures, because when we talk about sunscreen, most of the people think this is important to protect us from the skin, but when it comes to application, it is very, very different. When you talk about the reported estimates of using sunscreen, it in the different country, in the different community, it ranges from 7 to 90%. So factors which helps you to adhere to the sun protection regimens, and probably females are more responsible for using sunscreen. I see many of the people who comes out from their, hospital or anywhere, they always have this sunscreen in their, purse, because male has a smaller purse, and I found any male in my whole of the career who are having the sunscreen in their pocket to apply before they go and they're exposed to the sun. So sun sensitive phenotype, greater perceived risk of skin cancer, yet greater perceived benefits of sun protection or screening, and physician recommendation for screening or prevention. These are the few factors which make you adhere to the sun protection recommendation. So people with lighter hair color, blonde or red, are more likely to participate in protective behavior, because it is always said that you're more at risk to have the skin cancer. So even if the desire and intent to engage in sun protection practices are present, probably public health implementation is a very, very big challenge, and I am not having any idea how to deal with that. So recent work by Leon et al. Suggests that general population who reports with sunscreen are not doing so effectively. As you can see, when you're more exposed to the sun, your vitamin D level will be, high. So compare with those who use the barrier methods or sun avoidance, probably you will find less vitamin D level. So although I personally don't agree with this, in most part of the, world, probably people are not now more homebound, where they have the laptops, they have the mobile to play. So sun exposure has really been a big, big issue in past few decades. So individual, coming to the secondary prevention, and secondary prevention has again, which is 2 parts: early diagnosis and treatment. Early diagnosis is, ensured by screening. What is the screening? To diagnose cancer at earliest stage when you don't have a symptom. It can be anything. So increased public awareness is very much important about the signs and symptoms about the, skin cancer, and knowledge of skin self-examination practices, you need to teach physician about the skin examination or skin examination by the physician. American Cancer Society, although recommends self-skin examination of all body area, including the back of the legs, scalp area, but there are various areas which is very, very difficult to inspect or which is beyond your reach, and it is very difficult to go for. So what is advisable? You need to go for the skin examination by the physician. So who can be the physician? Any physician who are engaged in such kind of practices, or skin specialist, which is called dermatologist. So in a population-based telephone survey in Australia, very less number of the, participants examined the skin of the whole body for past 1 year, but only 20% of the male who were over 50 years did that. So it is, Australia, melanoma is a big problem, and probably all recent, all early studies were done in the Australia. So many of the people are dying every year because of the melanoma, but their practices are still not, justifying what is the incidence. So skin examination by healthcare providers demonstrated a series of challenges. An effective training program is very much important, who can teach you what is the best way to do the, self-skin examination. And there are a number of vigorous educational programs has been designed for this purpose, including an interactive case-based program called InformID, which is internet-based program for melanoma early detection, which is available. If you find any issue, you can go online and, make yourself more informed. Among all physician time constraints, probably we all have competing morbidity and patient embarrassment was reported, because many of the times patients are too much embarrassed, when you tell them that we need to examine your, body for the skin to, to check for the early detection of skin cancer. But many of the times patient, for the high risk of the cancer demand for the complete examination, they want their mole to be checked, and, they want, other facility to be facilitated. So what is therapeutic intervention, which is also called the chemo prevention? What is chemo prevention? You use some chemical or drugs or compounds which used to, change the, prevent pre-malignant molecular or histological lesion to the invasive lesion, and especially in the high-risk group. So what has been tried, anti-inflammatory drugs, in particularly, acetyl salicylic acid, epiglottilase, which is available in the green tea, curcumin, vitamin D. Other are urindac in the atypical nevi and lipid-lowering agent. But, whatever has been used, but till, this point of time, none of this agent has been found to be an effective chemotherapeutic agent, which is an effective modality to prevent pre-malignant, lesion to convert into the invasive cancer. So what are the research trial on primary prevention? So, melanoma control measures was as, old as 1960 when it was started in a country like Australia, as I already mentioned, and primary prevention strategy, they started in 1980s. So thickness data from 1991 to 2002 showed a faster increase in, thin invasive melanoma incidence compared to the thick because of the early detection. But it was across, although mortality rates were stable in all, age groups. So reduction in thin melanoma incidence were observed in the younger people, which were less than 50 years, suggesting an impact of early detection and a skin awareness campaign rather than the primary prevention. So self-skin examination has been to do as a screening modality for melanoma, but, as for the standard screening modality, it must save your life over the period of time. That means it must have the, mortality benefit, which has been shown in other cancer like breast cancer, lung cancer. But as far as the, melanoma is concerned, there is no such mortality benefit which has been observed in various studies by Pevey, Pallet, and the effect of self-skin examination was even greater in men and older patients. So till today, United States Preventive Services Task Force, which is, almost an authority in guiding people across the globe to adopt for various screening modality. They don't recommend self-skin examination as a screening modality for the skin cancer, but they recognize the potential benefit in high-risk group. So these are the, landmark trial, which was all community-based studies, by the Atkin et al. And they were, in Queensland, Australia. The second was Cinder and the Sweater and the Ketanic. All, endpoints was how was it effective to reduce the mortality related to the, skin cancer. So most of the, study resulted that, yes, you will be able to detect thinner melanoma from the thinner type. But as far as the mortality benefit was concerned, none of this trial, which was randomized control trial, came with a mortality benefit data. So general versus targeted approach, as I already mentioned, by various agencies, they have already mentioned that if you do it in the specific group, it has some role. So targeted approach has been, advocated. And as far as the cost effectiveness is concerned, economical, it has been, stated in various studies that this is a cost effective means if you try to do it in a high risk individual. So these are various risk prediction model of melanoma. This is a study published in Cancer Epidemiology Biomarkers. So you can go through it. There's another study which talked about how you can strategize melanoma screening in era of novel treatments. So they all talk about, and they all advocated that yes, for the general population, it is not, very much beneficial, but for the high risk patient, you must go for the, skin examination. So awareness is the need of hour. You can make them awareness, and you must try to make people aware by all awareness tools. So take home message is significant benefit of melanoma screening demonstrated a benefit as far as the high risk patient are concerned. Primary prevention results are encouraging, but not quantifiable for several decades, because it takes, much more time to make people aware and get the results, probably 20 to 30 years. So there is no absolute proof of mortality reduction from various randomized control trial as far as the, self-skin examination for skin cancer screening. So implement a targeted screening program in public health domain has a potential to save life. So, the last slide to conclude, IA in illness is isolation and crucial letter in wellness are we. So we need to work together to have an effective implementation, because we are the part of healthy, health community, and health community have hope, and those with hope have everything. So we have to be optimistic and try to convert every difficulty in opportunity rather than being pessimist who thinks every, opportunity as a difficulty. Thank you very much, and congratulations, Alyssa, once again for this wonderful arrangement. Thank you. And if you have any question, I will be very happy to answer them.
Dear Dr. Abhishek Shankar, thank you for finding time to give the presentation. You have done your best. And the next presentation will be in Russian, so I will introduce the next speaker in Russia.
Because of this disease. So, when we have this melanoma at around 4 millimeters, still 10-year survival rate is less than 50%. It calls that melanoma has a significant invasive potential, and it's metastasizing to mostly 50% of patients. So these cells are penetrating into skin, and if it is 0.8 millimeters thick, the risks are practically fatal. Look at the melanoma, how it is shown by different artists who also were facing melanoma themselves. And as you, Mr. Abhijit Mr. Abhishek previously told, that this disease is a monster which penetrates in the depths of your skin and gives a metastasis. And though it is we can easily cure the thin melanoma, and it has a good survival forecast, which I would like to note. And I would like to underline that whenever we try to put a diagnosis of melanoma, we must know that there are factors and risk groups for melanoma. Number one is, of course, UV damage to skin. Mostly our light skin potential patients are also in the high group of risk. Of course, dark skin ones, they also are exposed to this risk, but still. Then sunburns, especially when you're a kid. Then if you're visiting these solariums to get the sunburn skin, and UV therapy, and if you have all this, if you have your family genetic predisposition to melanoma, if you have immunosuppressive drugs, so I mean these factors are very important. Now, as per Fitzpatrick's classification, we have 6 phototypes of a skin, and left 1, left 2 from the left side, number 1 and number 2 are the types of skin which are exposed to a highest risk of melanoma. But anyway, all these phototypes of the skin, all of these 6 phototypes of skin, they should anyway take care of melanoma. So we have so here, please, at the skin, look at our patient who has risk factors. Look at the left picture. She's a young girl, but her body is has a lot of these spots and points, and you know, it looks like a sky full of stars. And you know, these patients are in the group of risk. And you know, her mother of this girl, she was a nurse, and she like knew that your kid, this girl, is in the risk group. So, and we have taken a bigger picture of one of these nebuses, and we have identified 1 millimeter melanoma at early stage, and it is a good forecast for her. So let's hope for the best for this girl. And we also have our patient with giant nebuses. All of us, we see such a kids, you know, even they're kids, or if they are big at the adult age, but we have published several articles on this theme, that patients who have a giant size of these nebuses are at the highest group of risk. And as this child grows and becomes an adult, we must you know, observe his health, not only us, but also he, of course, the family members, everyone should should be careful about their health. And you know, actually here we have also our oral cavity, esophagus, and even the nose, even paranasal sinuses. Everywhere in mucosas we can also have melanomas, and you know, these melanocytes can also be distributed there. So other specialists, like for example, gynecologists or proctologists, everyone should be keen here by biopsy. And unfortunately, uveal melanoma, which we now see on the screen, it is unfortunately incurable disease which destructs the mucosa of an eye. And you can see, ophthalmologists sometimes they're not using at the bottom of an eye, and that's why they can simply miss this opportunity to identify this disease. That's why we think this is very important thing. And unfortunately, for example, our doctors know that we can have a cancer, esophagus cancer, and so that we can have atrophic gastritis on the beginning. But who knows that these nevus can be a reason for melanoma, can cause melanoma? This is the question which we must think about. I know that most of you know the answer for this question as top professionals in your area, but still I would like to share some sort of my concerns, my views on this. You know that and you know, we have nevuses which you are born with, and you have nevuses which are developing in the course of your life. These are the things which you have to especially take care of. We have, oh, sorry to say this, adult melanoma, sick melanoma, which is 2 millimeter long melanoma. It can easily identify, because, you know, even if you're not a doctor or specially trained person, you can easily identify it. And to identify melanomas, there's no need on special like computer-aided tomographies or special diagnosis. You can easily do it by simple check. But unfortunately, our doctors are simply neglecting this simple rule. Sometimes our patients come here that they say they have previously been in hospital, they have, but you know, they had a melanoma on their in their hair or even in their skin, and you saw none of the doctors even managed to do a complete examination of a patient, though if he could have done it, he would inform everyone and it could have prevented disease. So we must know that but you know that at early stages, it is not that easy to identify melanoma, to put a right diagnosis. Here, it is very good thing to use a dermatoscopy, which is very good non-invasive method for diagnostic of this melanocytory and non-melanocytory malignancies in your skin. So whatever happens in your skin, it can easily be identified with dermatoscopy. Especially this is useful for patients with with nevuses which are not born with, but which have developed in the course of their life. So, and please just keep in mind, for all of you, we are propose you use this ABCD method, the rule which was proposed in 1985. It was first called ABCDE, then it was ABCDE: asymmetry, border, color, diameter, and elevation or evolution. All of us who are dealing with diagnostics may say that this tool is too old-fashioned, but you know, of course, we have our contemporary methods. We can use more targeted, precise methods of diagnostics. But still, even for our other doctors who are physicians, for example, or for our medical students, or just for our family members, we can still use it here, because even not being a doctor without any special medical training, all of you can help your family members, friends, or people around you to identify it. For example, the diameter we can have is the diameter should be bigger than 2 millimeters, and we are using 2D dynamics, and also we are doing 3D diagnostics now, which is a professional diagnostics. It means that D is dermatoscopy. It means that you use this dermatoscope as a tool for identification of melanoma, and also for us to be able to show this 3D role. I would like you to look at the main clinical and histological options of skin melanoma. First of all, you know that this is surfacially distributed melanoma, which is growing or vertically or radially. And we, unfortunately, which I have shown you, I mean, this is scary pictures. And also we have junctional melanoma, because and also you see, you cannot easily identify it, because sometimes it can be with you for several years, and then this tumor suddenly becomes invasive. And also we have acral lanuginosis form of melanoma, which is very also risky form, because you know, if it sometimes can be on your plants, it can be on nail beds, you know, or on if you're bald, for example, for a bald man. It is also very important thing. And you know, there are melanomas which are growing not that fastly, but you know, whenever we say melanas, melan means black. So it is black, but sometimes we have without melanoma without any pigmentation, so it can look a bleak white, you know. So whenever you are looking here at surfacially spreading melanoma of a skin, you can see how it looks like. And this is junctional melanoma, please. It can be both symmetric and asymmetric. Here you see no asymmetry. It looks like, you know, it looks like it's of a perfect shape, but still this perfectness can cost you a life. And we can have these borders, you know, these borders, as you can see, they are bleak. It looks like a geographical map. And when I would getting back to junctional melanoma, I would like to see that in junctional melanoma, our ABCD rule may not even look, you cannot even see it, and see color, polychromy or color. Sometimes you see it cannot be so dark or so white. Sometimes we can see a mixture of a color, combination of a color here, or shades of pink, of a black, or look here, please. Here we have red, pink, black. Whenever you see this red color, keep in mind that or it can be an inflammatory process, or if this inflammation is still with you, is some sort of neoangiogenesis. It means that when you have this tumor, it causes a growth of vessels, and this is the reason for this color. Sometimes the color related rule will not work out in the case of junctional melanoma, so please be careful that you know there are some exclusions out of this ABCDE rule. And we are regarding our surfacially spreading melanoma, the diameter. When you're diagnosing it, sometimes if diagnosis is bigger, extending 3 millimeters, it is not good. This is the early stage of melanoma, which is less than 5 millimeters, but still this is a melanoma. And this is also one of the exclusion of our ABCDE rule. Please look at the skin. Now, this E. Yes, ABCDE. E rule is evolution, development of a disease. Look at our patient. Look at the size of this stain. You see, it grows for 25 years on the cheek of these poor women. But it is very strange that within 25 years, can you imagine, a quarter of a century, no one of your friends, relatives, and even took care about what is happening to your face. It is very strange, really. And if you are look here when you were talking about E, look at the picture of this lady. First picture is May 2008. There's a small pinkish stain on her face, and after 9 years, she comes with such a bigger and clearly manifested melanoma, which is growing for 10 years. We can understand that the melanoma of such a melanoma grows, but still you know, it will give its metastasis as early you will identify it, as successful as more successes you will reach in combating it. You know, this junctional melanoma grows very at a rapid stages, at a rapid manner. This melanoma grew within 6 months, and you see, actually, this lady was very worrying about this situation, and thus she addressed it to a doctor. And this junctional melanoma grew to 5 centimeters for 5 years, you know, but still, thanks God, she had no metastatic impact on her body. Probably she was very lucky with this, but still I would like you to keep in mind this that this junctional melanoma sometimes gives you a chance for survival. This is a classical conventional melanoma. All these ABCD rules can be easily seen here. Everything is complied. We can see both the color, diameter, everything which is on the textbook based on which we were studying in universities. Look, we have these early forms of melanoma. Still, it keeps the picture of your skin, and the very important thing that even with these ladies, that she has a clinical symptoms of all this pigmentation, pink color, which you can see, and of course these vessels form also vascular drawing we can see. And now we can see a man. He's very. He's like around elderly. For 4 years, this melanoma was growing, because you know it is very strange. Of course, he cannot. He sees back, but none of his friends, family, no one was taking care that he has this. See. People are identifying melanoma at very. How to say, at the very advanced stages, when it's bleeding, or when you feel the leakage of liquid from it. And this is also one of the forms of superficially spreading melanoma. As you can see, its size exceeds 5 millimeters. This dermatoscopy you can see. I mean, these classical conventional pictures is clearly seen. And we can have these pigment fosses and spontaneous regression fosses. So all these things, which are, I have told you, all these features about melanoma are clearly seen here. And here, all this ABCDE rule is also clearly seen in the pictures, which I'm showing you. I will be showing you thousands of these melanomes. Unfortunately, human being, when see something, if you will see it, you will never forget it. Would you be would it be in your life, everyday life? Would it be in your practice? If you will see it, you will never forget it. And of course, you can do a biopsy, or you can send your patient to visit oncologist. And here we also have other forms of melanoma, and it is very also important for us to keep in mind this junctional melanoma, because you know we don't have here asymmetry, but still all the rules of B, C, D, E, C, of course we can see it. And this also the man, and on his back we can see the melanoma, and the diameter exceeds 2 centimeters. And it is very strange that no one was taking care. Of course, it is not the issue of you and me. But anyway, when patients come to you, please ask them to take their clothes off and to do examination of their body. And now you can see on this lady's left brow, above your left brow, all these features which are peculiar to melanoma. And if you are not touching melanoma, then what will happen for a century or for decades? For decades, trust me. I mean, this patient has, risk of these metastasis at a super significant rate. And here we have at this lady's palm, we can see also this melanoma. For 10 years it was growing on your palm, and it is very strange that, you know, for 10 years she was surprised with what is going on with your hand. And the same thing, actually, we can see all these ABCD things here with our other patients. And you can see on these surfaces, this acral lanuginosis melanoma was not, you see, it cannot progress so rapidly. Sometimes it can go for years, or for decades even. You know that the skin can cause different sort of tumors. I mean, they can be a malignant tumors, they can be a general tumors. So sometimes, I mean, we can have this keratosis. This old lady on her left cheek, it's like 13 millimeters in diameter, this tumor. It is not that easy to distinguish whether it's a melanoma or whether it is skin cancer. So we can do this brain line pattern and decide what is happening actually. And we understand that this is seborrheic keratosis. And now you can see the second sample of keratosis. It is, of course, you can even conclude it with using your the dermatoscope. So we can see a keratin here and another keratosis, which it looks like, it resembles like junctional melanoma. So it is not junctional melanoma, but anyway, it can easily be this. And basal skin cancer, which can easily be cured by invasive surgical way, and still it looks like a pigmented skin melanoma. So anyway, you need to do a biopsy to make a conclusion on this. And here we have this basal skin cancer. Obviously, it is not that dangerous as melanoma, but still, you need to do a biopsy. I would like to reiterate it again. And it looks like a regressive melanoma, so this is just a skin cancer. Anyway, here we also have a plain cell cancer. And here we, you know, field melanoma is #1 causes for deaths, unfortunately. Also skin cancer. This is a symmetrical tumor. You can also hemangioma. It looks like junctional melanoma, but look at here we have looks like a vascular. It is not that plain, it is not flat. And if you will even touch with the dermatoscope, you can easily, you see when you push on it, it suddenly loses its colors. It is very important thing. And there also we have second hemangioma, which looks like a junctional melanoma, though it is not a junctional melanoma, which we have to keep in mind also. And look, please, how our left picture resembles a skin melanoma. So this is hemangioma. One more thing is dermatofibromes. They look like melanoma, but you can see that these are tumors and dermatofibromas. They look like a white stain in the center, and you see when you are pushing on this dermatofibroma, it gives you such a pictures. And here we have this granulum. It also looks like a junctional melanoma, but unfortunately it grows very fast within like a couple of days. And also we'd like to show you pictures of some nevuses. but for us to be easy in differentiating between nevuses and melanomas. Because when you try to decide on whether it's melanoma or whether it's nevus, I guess it's better to do a melanoma. You know, even if they will have a couple of scars on their body, it would be better than having a tomb for them. So we must try to save their life. That was the thing I was meaning, dear friends. And you see, I see all these dermatological features at this picture of melanoma. So I think that these things should be removed in surgical way. And a very important thing which we can see, feature which we can see now, these blue nevuses, they look like melanoma, and also it looks like a facial melanoma. The same thing. I have several pictures. Please look at this and keep in mind while doing differentiated diagnostics. Here we also see a certain asymmetry. We can see that the pigmentation is lost here in the center. So it is very also important to keep in mind. And the next thing is that also if we have this superficially spreading melanoma, and here we have some sort of complex nevus, which has like a borderline nevus and central nevus, and this is a nevus which a patient was born with. You can see that the kid was born with this nevus and grew as an adult. So because you can easily see the picture of a skin, and it is very important because this globular pattern is here. Because if you do not have this globular pattern, obviously it means that it is melanoma. And we have here a combined nevus, because we have here, it looks like melanoma MC2, but anyway, we think that it would be better to remove this because it has some sort of features of the atypical melanoma. Of course, it would be better to remove. Whenever we say about removing, you should keep in mind these hyperdiagnostics, because, you know, unfortunately in our former Soviet Union countries, this melanoma, I mean this diagnosis is put at the advanced stage, unfortunately. So, but still, of course, we must raise public awareness. Probably sometimes when we are raising this awareness, we are scaring people, and they are, of course, rushing to a doctor to undergo this medical examination. But probably this is the right way. So you're scaring people, but still they understand that they are at risk and that they must be careful about their own health. And for example, also, for example, in Germany, we have that 0.7 millimeters, the thickness of melanoma, but in Russia, they have 4 millimeters. It means that, you see, in Germany, they are focused on public awareness. That's why people are rushing to doctors, and that's why they are getting this good result of survival and reduced mortality rates. But look at what we have. If we have hyperdiagnostics, and if we have hyperdiagnostics, this is the diameter of this melanoma is 0.6 millimeters, and of course, you know, this doctor was, you know, was super careful and super serious in examining these patients and identifying such a small stain. So, of course, for you as a patient and for you as a doctor, it is very important to be that thorough, to be easy to identify this. It is you who will decide which side you belong. And dear colleagues, and I would like to say some words about our clinics. Our first we are first affiliate in Russia. We represent general colleagues Hadassah clinics here in Russia, Skolkovo Center in Moscow, and I am extremely happy to work in this clinic. And please kindly address me if you would like to ask any questions for consultation, seek a consultation. Please, here are my emails and my phone. Please, I will always be ready for you. And please, thank you so much. And we have no question, but we are very appreciate your presentation and everyone who are listening to it. We are so sorry that our Turkish colleagues couldn't take part in this event due to the COVID. Unfortunately, they were found as COVID positive. So taking this opportunity, I would like to pass the word to Mr. Danka Konstantinov.
Thanks, man. So good morning, everyone. Thank you once again for the opportunity to present on your meeting once again. And hello to everyone else that I know from before. I'm sorry that I couldn't log in earlier, but it's a little bit busy, as you all know, with the whole COVID craziness everywhere. So I'm going to briefly go into the surgical options for the malignant melanoma. And I would really want to start with some of those photos that I'm presuming most of the people were desperate to go, especially in those COVID times. So I'm sure that everyone would like a photo like that, or maybe something like that. But the main problem in having those lovely, lovely beaches is the sun. And what exactly is related with the sun is the UVB and the UVA rays, which we all know goes to burns. And when we have a lot of like pigmentation in the skin that can be damaged, and our DNA can be disrupted, and it can lead into a cancer. So just briefly, a little bit for the medical students who are attending the conference about the UVB and the UVA rays. So they have a different depth in the in our skin, and based on that depth, they can damage the skin in certain levels. So the skin, as you know, is mainly organized from three main layers, which from my point of topic is those layers, when they've been damaged and their DNA is being disrupted, it can lead into skin cancer. So there are different types of skin cancer, and mainly the skin has been made up of different layers, which includes the squamous cell, the basal cell, and the melanocytes. The melanocytes are the ones that are responsible for our skin pigmentation or the color of the skin. And when their DNA is being disrupted and they start becoming cancerous, that's the condition when we're all calling it malignant melanoma. The malignant melanoma is affecting the skin mainly, but it can also affect the eyes and the lining of our gut, as well as the anorectal area. The most important thing in every cancer is the depth and the spreading. So why is the depth so important? Mainly because when the cancer invades the skin, it can grow into the blood vessels, and it can affect the lymph vessel, and then it can spread to different organs. So just simply in the melanoma, if the melanoma is, for example, thicker than 0.76 millimeters, it can have a curative rate of up to 96%. When it's more thicker than 3.5 centimeters, which you can imagine it's not like a big distance, the curative rates dropped 60%. The etiology of the malignant melanoma is unknown, but there are two main factors that have been discussed for the past 20 years. Most of them are related to the environmental point of developing the malignant melanoma, including the sun exposure, the artificial ultraviolet source of exposure, the number of the potentially malignant melanocytic nevi, the socioeconomic factors, which includes the fair skin, the red hair, the freckles. People in Western countries are much more prone to develop a malignant melanoma when they have a chronic or an excessive amount of sun exposure. And we also need to mention the genetic factors, because there are two proven conditions that you can have a familial melanoma and the xeroderma pigmentosum. I'm sorry if I'm repeating one of the previous speakers. That's why I'm just going to go briefly into that. So the skin cancer is very, very interesting, mainly because there's a huge differentiations in between its spreading by ethnicity and also by sex. As you can see on these figures, the Caucasians are 20 times more likely to be diagnosed with skin cancer rather than the African Americans, which is definitely related with the level of the melatonin that the African Americans has in their skin, which also affects the 5-year survival rate, which, as you can see in the African Americans, is much lower than in the white Americans. Also, when it's been redistributed by in between males and females, you can see that males are more predominantly in the age after 50s rather than the females is being diagnosed much younger. In that diagram, you can just see like the different pigmentary phototype from the Fitzpatrick scale that has been published recently. As you can see, the level of melatonin in the skin is having the UV resistance, which is basically the suntan, and it's decreasing the cancer risks. So it's funny how most of the European and the American people wants to have that suntan, but it's not as safe as it looks like. So we need to use a lot of sun washing and protection when we're going on the beaches. The melanoma skin incidence, as per from the last global service trial in 2018, has been mainly focused in the Western countries in Europe, in Australasia and New Zealand, and in United States. As you can see, there's a huge difference in between the continents in spreading the melanoma in between males and females. It's the same redistribution when we're talking about the incidence even in Europe. As you can see, most of the Western countries has a much more prevalence in developing the melanoma rather than the countries, for example, from Eastern Europe. The incidence varies in between the countries, and for example, in UK, from 1990s up to 2018, there is a 135% increase in incidence of new diagnosed patients with melanoma. This is the 5th most common cancer in both males and females in UK, and one in every 4 patients have been diagnosed with melanoma under the age of 50. But still, the exact cause for that type of cancer is still not clear. There's a lot of different theories and hypotheses, which I presume the main one is related with what is called the dysplastic nevus theory. As you can see on the diagram on the left-hand side, there is a certain amount of time and progression that needs to happen in between a benign or what is called like a simple nevus to turn into the nasty metastatic malignant melanoma. And it's mainly related with losing a lot of its DNA structures and having like a mutation mainly in the 3 most common mutating factors, which are the KRAS, the BRAF, and the CDKN2P protein. As I've heard from the previous speakers, there's a different type of skin lesions. Some of them are with huge malignant potential. Some of them are like absolutely benign. But the important thing in a surgical aspect is the one that are the borderline, the one that you cannot clearly identify whether they are malignant or benign. And as I can see, some of those benign moles can look quite pretty and attractive, but we all need to know what is a normal, what can be turned into malignant. So the early detection is of probably the most huge importance in dealing with those type of patients in cancers, because as early as we can detect the condition, the more high is the risk of curative outcome for the patient. So as you can see, there is a clear ABCDE type of pattern for malignant melanoma, and every single letter is meaning for something. For example, A is for asymmetrical shape, which you can see here that what is between symmetrical and asymmetrical. B is for the border, whenever there's like a regular or irregular borders. We can have like change in the color from a normal, like a single color, to multicolors type of variation, and especially like the diameter or like the size. So when it's more than like 0.6 millimeters, we can always need to think about malignancy. And the last one that is been recently uploaded is the evolving. And by evolving, they means whenever you have a nevus in your GP or your dermatologist is looking after that, And when it starts changing over time, such as like that mole can start growing in size, it can change in color, it can become itchy, it can start bleeding. These are all the signs that we need to be aware, and as a patient, people need to look after. The most important thing, as my colleague before me said, is detection. So dermatoscopy is the main and easiest, absolutely pain-free way that a patient can be tested for a potential malignant melanoma. Most of our colleagues, dermatologists here in UK, are doing a dermatoscopy clinic where patients are coming, spending like about probably 2 or 3 hours, and have all their body checked top to bottom for potential spots, and they're even counting the numbers of the potential like borderline or like even like benign nevi that can turn into malignant. Once we had a spot that is potentially borderline looking, the next step as a surgeon, we're always recommending that we need a biopsy. So every suspicious mole that can be turned to malignant, we need a definite histology result to know what we're dealing with and how we can deal and how can we cure the patient. So the easiest thing that even like a GP can perform is a punch biopsy, which is a small skin sample by pressing a circular blade into the skin and send it to the pathologist. Excisional biopsy or incisional biopsy is 2 surgical procedures that can be done under local anesthetic. And the sentinel lymph node biopsy is more accurate, but it's very complex and needs an experienced radiologist or surgeon, which is including a radioactive or a blue dye, which is injected into the area where suspecting a cancerous tumor. And it allows for the lymph node to absorb that dye, and then we can trace it. I'll talk a little bit in details in a second. So the main areas for redistributions for the melanoma, as you can see on the figure, are slightly different in between males and females, with the main prevalence in leg in females and the main prevalence in the trunk for males. But even that the melanoma is being known as a skin cancer, it has a few hidden areas that sometimes have been missed, which is the nail melanoma, which is the eye melanoma, and there is a melanoma affecting the gut, the mouth, and the vagina, which everything is being explained with the embryological development of the skin and the cells in the skin and the epidermis, which are the same level as the one in the GI tract and in the nail. So to move a little bit forward, I'm sure that somebody spoke about the 4 stages of melanoma, but just briefly to give you an idea that going from stage 1 to stage 4, it's not a huge progression in the skin, but it's mainly how it's affecting the lymph nodes and the blood vessels around it, and whether it's spreading into the other organs or not. So when we're talking about the level of invasion from a surgical point, we're usually using the class classification, which is mainly into 5 levels. And it's been designed, it's a histology classification, and it's mainly affecting the depth of the tumor invasion into the skin layers. The 5-year survival rate, it depends massively whether we're talking about localized disease, regional, involving just the regional lymph node disease, distant metastasis, or other organs. The surgical treatment also varies, and it's, in general, melanoma is a complex disease, and it's not as simple when we're saying that, oh, we have a melanoma, so we just need a surgical treatment. Usually we need a dedicated MDT, but starting when we're talking about the localized disease, the best possible treatment is just to remove the melanoma, including the area. When the melanoma is being diagnosed early, the 5-year survival rate is very high, up to 92%. The white excision is the gold standard, and when excised, the specimen margin is evaluated by the breast wall thickness classification, as you can see here, which is including the depth from the cancer through the epidermis, the dermis, or the subcutaneous fat. And as you can see, the breast wall thickness classification also gives a difference in the 5-year survival rate. So the more the tumor is progressing into the skin and reaching the subcutaneous fat, the lower the 5-year survival rate will be. So the current recommendations for resection margins for widespread excisions is mainly that we need to have at least 2 centimeters for the biggest tumor, which are more than 4 centimeters in depth. The next step is a MOX micrographic surgery, or MMS, which is an improvement to the local excision, mainly because it improves removing the visible cancer and a small margin around it with the healthy tissue all at once. The MOX surgery mainly allows the surgeon to verify that all the cancer cells that they can see have been removed at the time of the surgery. So we don't need to come back if for some reason our pathologist is saying that our resection margins are not clear. This increases the chance of cure and reduces the need for additional treatments or additional surgery. You can see briefly from the diagram how, for example, if we're having like a lesion on the head, we're seeing that lesion. We can remove the first layer, then we're seeing that it's much deep, so we remove the second, third, and fourth layer until the surgeons are absolutely happy that we're reaching a healthy tissue. Next step is when our cancer starts spreading into the lymph nodes. So in advanced disease, the lymph node involvement is the main factor determining the survival rate. In clinically negative lymph node, the regional lymph node disease, from surgical point, we're usually searching for the sentinel lymph node, which means the sentinel lymph node for the medical students is the first lymph node that has been affected after the tumor. And that concept has been involved into the treatment of the malignant melanoma since the 1992. So the concept is to make a potential lymph node and lymphatic mapping, which will help from surgical point to know what part of the lymph node drainage we need to remove. As you can see here, the whole concept is to inject the dye, as I can speak before, into the tumor, and whether it's going to be a blue dye or some like ICG type of dye, which I'm going to show a few images later. The idea is that the tumor cells, when we have a lymph node involvement, that dye will go from the cancer itself to the lymph node, and then we can detect them. You can see the national guidelines from the melanoma surgical committee has been changed dramatically from 2012 until 2017, from the statement that the sentinel lymph node should be performed for tumor which are thicker than 1 millimeter and have or don't have an ulceration, to the statement that the sentinel lymph node biopsy is not recommended for primary melanoma less than 0.1 centimeters almost, but it's recommending for the borderline. So in general, the sentinel lymph node biopsy has a sensitivity of 95.3%, which varies, depends in which area we're injecting the dye. And it's the best in the groin because it's almost 100%, as you can see, and it's less in the neck, which is about 84.5%. Unfortunately, as every test, it has a false negative result, which is about 12.5%. But on the other hand, the sentinel lymph node biopsy is the best predictor for recurrence and survival in patients with clinically node-negative melanoma. The sentinel lymph node biopsy carries significant less risks of complications compared to like a proper lymph node dissection, with an overall complication rate of 5%, mainly into infection, lymphedema, and hematoma, and sometimes a nerve damage. The new modern way of detecting the lymph node, it's now what it's called an ICG orientation lymph node chasing, which is mainly into putting indocyanine green dye, but not into the cancer. Here we're putting it into the bloodstream. And then with a specific X-ray camera, which it's mainly been designed for laparotomy and laparoscopy type of purposes, where the surgeons can test the viability of the small or the large bowel. But it also been seen that if you're putting that indocyanine green into the body, and if we had a damaged lymph nodes, they can also be seen in red, like with a very, very light green type of pattern, which is very helpful from surgical point whenever we're having a case that we're doubting whether some lymph node is being affected or not, and the other principles are not working. So this is one of the things that you can think about it. So going from a sentinel lymph node biopsy to the main lymph node dissection, we have two patterns for lymph node dissection, which are the prophylactic and the therapeutic one. Which the prophylactic lymph node dissection is mainly removing the lymph nodes in the regional area from the primary tumor as a prophylactic procedure during your having your white spread excisions for the malignant melanoma. The other concept is the therapeutic one, which is mainly being performed as a delayed procedure only when we have a definite recurrence in the lymph node basin. Regional lymph node involvement can be diagnosed cytologically, even like when we're having like a frozen section with a fine needle aspirate or image-guided biopsy. Therapeutic lymphadenectomy is the preferred treatment in patients with regional clinical lymph node involvement from the malignant melanoma. The 10-year survival rate in patients with metastatic involvement in the lymph node varies a lot, but it's about 20 to 40%, comparing to the early stages when it's about 94%. There is a certain condition called a transient metastatic disease when we're having a skin or a subcutaneous metastasis, which are more than 2 centimeters from the primary lesion, but are still in the same lymph node basin. In the absence of distant metastasis, surgical excision is the treatment of a choice when it's feasible for them. But sometimes, as you can see on the image on the right-hand side, there are too many and they're not possible. In those conditions, we're recommending a regional chemotherapy in the form of isolated lymph perfusion or isolated lymph infusion, which is the reserved also for the unresectable recurrent diseases. I'm not going much into details regarding the chemotherapy and the radiation therapy because I know that there are few colleagues that are preparing presentations about it. But what is the ILP, or like the isolated lymph perfusion? It allows higher concentration of a drug to be administered to the affected lymph without systemic toxic effects. So the isolated lymph infusion involves percutaneous placed venous arterial catheters to allow infusion of chemotherapy via an arterial catheter and a pneumatic tourniquet just to compress the lymph, so none of the chemotherapeutic agent can go further up into the body, as you can see on the image. There is no randomized controlled trials in between ILP or IOI, but recent study shows that the overall response was high with ILP rather than with the IOI. And then you can see like what it looks. This is the image for the intravenous lymph infusion with the catheters and the hemofiltration open. And in further details, the melanoma, as I said, it's a very complex disease. It's a genetically heterogeneous disease, and there's a lot of mutations that are being developed and continue to be developed, which are associated with melanoma. And all those mutations have a huge clinical implications on patients' outcome and survival rate. So if melanoma continues to progress, the main spots of metastatic melanoma are mainly in the brain, lung, liver, in the small intestine, and in the bones. And as I said, a melanoma is not a one-man job. It's mainly like we need a dedicated team, which usually involves at least a surgeon, a medical oncologist, and a radiologist. So what are the main conclusions that I can make in my presentation? So the malignant melanoma is a very common and a very socially important disease. Screening programs and early detection can be life-saving, and they are life-changing for sure. Metastatic melanoma needs complex treatment, and options are strongly individual, so every patient deserves the best possible treatment available. And when I'm saying available, there are new trials, new drugs. Like I'm sure that my colleagues can give more details regarding like the BRAF, the KRAF, the wild type mutations, and so on. And I really like that photo that the cancer treatment, no matter whether you're treating melanoma or some other type of cancer, is always a team play. So don't forget it, it's not for solo players. And as I'm working in the peritoneal malignancy unit, I'm just going to briefly give some details about a few melanoma patients that we had. So for the last 25 years in Basingstoke, there are 4 patients that have been operated with malignant melanoma. One of those cases was more than 10 years since his initial wide site excision for melanoma. And the case was reported as in remission, so the patient was supposed to be clinically cured. All the cases have been done more than 15 years ago, so unfortunately I don't have any images for those cases. But looking at their data, it was a very poor survival and a very high recurrence rate. The complete clearance was only been available in 50% of the patients, and none of those patients lived more than 5 years after the operation here. So that's from me. Any questions? I'm happy to answer.
Thank you, dear Danko. I would like to thank you for your wonderful and highly informative presentation. You managed to convey such an urgent and complex topic to the audience in the simple words. I hope that in the future you also would be able to participate in our scientific and educational events. Thank you.
Thanks a lot. Thanks a lot for inviting me. Bye-bye.
Predicting a fate. So, you know, for example, for Mongolians, they were called like that this is your destiny for everyone. Was like you are from Chinggis Khan, and for Uyghurs it was a Tengri point, Tengri mark. But in the medieval, in the period of Inquisition, because they were calling like, oh, you have a stain, you're a witch. And of course, it could bear a negative impact. And in Europe, in the Renaissance period, ladies were masking the stains from smallpox. So then it was using for flirting, some sort of accessory on their face to flirt with a gentleman. So, and now from geographically and from climate condition, obviously longitude, latitude, or ozone gaps, of course, they produce an impact on melanoma rate, morbidity rate, and you know, even Lancaster in 1956 has noticed that closer you're getting to equator, the higher is melanoma morbidity degree due to longer exposure to direct sunlight. And as we have already noticed, as per Fitzpatrick, we have 6 shades of the skin, and pigmentation is one of the key factors of developing of melanoma. As per Fitzpatrick, the first type, I mean those with red or blonde hair and white skin, are exposed to a higher risk of melanoma and UV harmful impact comparing to those with a darker skin. And such as Northern American countries, Europe, Australia, New Zealand, population is highly exposed to melanoma comparing to the others. And actually comparing to Asians ethnicity or to black people, and because the black and the Asians, they have a higher content of melanin, and that's why it prevents from negative impact of ultraviolet. And in 1978, Clark has observed 6 families, and 6 families which members were exposed to melanoma, and he came to identify the nevuses, a number of numerous nevuses on their body, and he described this situation as VK syndrome of nevus. So, in 90% of cases, the patients with surfacially spread melanoma are having these atypical nevuses, and these numerous atypical nevuses are increasing the role of the risk of melanoma development. So, it can obviously also be impacted by heredity, by autosomic dominant type of heredity. So people with whiter skin, blondes, or those with red hair, with blue or green eyes, are at the highest risk, or the one who having this atypic nevosis on the open part of skin with a heredity or such as melanoma on the closer relatives, or those who have over 100 of nevoses on their skin, or they have sunburns. And in Uzbekistan, as per our cancer register, in 2009 we had 3 cases of melanoma per 100,000 of people, and absolute amount was 989 cases, and in Tashkent we had a higher rate, which is 9.3 per 100 persons, and the lowest amount was in Andijan province. It was 0.8 per 100 persons. And also we have this lentigo malignant melanoma. It is it has a benign forecast, and we have a superficially spreading melanoma with relatively favorable forecast. We have a junctional melanoma with extremely unfavorable forecast, and we have acral langinose melanoma with extremely unfavorable forecasts, which you can have on your palms or on planta. Here we can, in 80% of cases in melanoma, we can use a target therapy because they are caused by mutations. And here we can use immune and histochemical, all molecular and genetic surveys and examinations while making these diagnostics of this pathology. And as we know that melanoma is a highly aggressive malignant tumor, and it metastasizes in lymphatic nodes, in the brain, in skin, in bones, and in visceral bodies. And it is very important that fibroblasts, macrophages, lymphocytes, and endothelium cells which are surrounding this melanoma are also play significant role in its further development. Therefore, we need to have these biomarkers, and of course we can use these targeted drugs which can drastically improve the results of treatment of melanoma. So we can have a better control, for example, using nivolumab for our patient, especially when we have disseminated melanoma. And also the Cancer Genome Atlas Network is very good classification, which divides melanoma into 4 genetic subtypes: BRAF, RES, NF1 subtype, and 3 times the wild subtype. So when you are talking mutation in RES family, in RES groups, we are activizing the signal path of EGFR cascade, and this KRAS and RAS amines are the products of activity of this gene, and they're included in this cascade. And this genetic research is very important for us to identify the number of mutation of melanoma. And today we have a lot of targeted prepared drugs fighting with melanoma. So, and also tools to forecast melanoma based on genetic research. So I would like us to focus on the target therapy of metastatic melanoma. It was for a long time called this extremely unfavorable disease. For example, here when we are selecting the tactics of treatment, we take keep in mind the frequency and the response rate and the time to response, and also the response time. And ESMO, as per ESMO 2019 recommendations on skin melanoma for the first group of patients. So we are based on mutant gene BRAF, and we use PD-1, CTLA-4 inhibitors, as well as BRAF MEK inhibitors. We have a clinical researches which are using which are studying the efficiency of combined use of BRAF MEC comparing to PD-1 and CTLA-4 inhibitors. And as per Roberts, when we're using the combination of BRAF MEC combination inhibitors combined, it becomes more efficient comparing to inhibitors of immune checkpoints when we are getting this unbiased immune response. And when for immune therapy, it is very important to give a time for immune response, and the features of this response actually depend on the response itself, the time of treatment, and also about some sort of pseudo progress. Sometimes we can see the number of forces is growing. And here, actually, for us, it is very important that we should follow these MEC inhibitors, because it provided a higher efficiency and higher survival rate if you are using CTLA and PD-1 or other options. And our 5-year survival rate reached 34%, even for patients with unfavorable forecast. But if we will compare our patients, we can see that the patients with BRAF MEC combined inhibitors, their survival rate 5-year reached 55%, comparing to the other groups who used monotherapy or combined therapies. And for example, this combi DIV with ipilimumab in the second line of therapy after progress on dabrafenib and trametinib. Of course, most of patients had certain results, because after this checkmate 067, we have seen that no matter the status of BRF, we can witness better survival rates, though we have no information on profile of a patient with BRAF gene mutation. As per combi DV researches, the 5-year survival rates was 90% when we were using dabrafenib and trametinib, though the result, the plateau was achieved after 4 years starting the therapy. And the survival rates with no progress were the same for 4 and 5 year survival. It shows that these long-term indicators stabilized, and also our LDH patients who have less than 3 foci in their bodies can be put in a favorable forecast group. And regarding this 5-year survival rate are different between immunotherapy and BRAF MEC inhibitors treated groups. They have equal survival rates within 5 years. So 38% of patients which we included in our studies, they have the normal level of LDH and less than 3 foci. It was 39%, and comparing to no progress survival rate, it was 19%. And regarding patient with brain metastatic, of course, breast EMEK showed better result comparing the one who were treated through immune checkpoint in monotherapy mode or combination mode. So they had a better frequency of report. In 125% patients took part in this COMBI-MB research, and it was the actually biggest examination on this population, and we have divided them into 4 cohorts. So patients with a higher with the higher intracranial response rate, they have reached a 60% of response rate. It was a very good indication. We think that, and then when we're talking about Checkmate 204 exam survey, it was actually focused on studying efficiency of inhibitors of control rates, and it was also very important that we had 22% of our patients giving this relatively low response rate. Well, then when other schemes of and other modes of treatment were used, and then they are getting back to BRAF inhibitors based therapy, we can see that when we have the patient with 3C or 4-stage melanoma, right, BRAF plus, obviously we're supposed to have vemurafenib or dabrafenib or combination of dabrafenib and trametinib as the disease was progressing. And when it was progressing, BRAF patients were also treated by antibodies to CTLA-4 IPI or PD-1. It was nivolumab or pembrolizumab drugs, and still we unfortunately face the progress of disease. So we should always keep in mind this result. We had some immunological changes. For example, infiltration or lymphocytes or expression PD-L1 on these tumor cells, as well as infiltrating immune cells which were induced by inhibitors of BRAF and the MEK kinases. It improves the immunity of the tumor, and of course it improves the efficiency of immune therapy. This is the end of my report, and thank you for your kind attention, dear colleagues. Well, dear colleagues, first, I guess now we are reaching our final stage of our conference, and we would like to pass the word final word to Ms. Jamila Pulatova, our head of chair, to conclude our conference. Please, Ms. Jamila, the floor is yours. Dear sir, thank you so much. I would like to thank all of our participants for sparing your precious time to take part in our today's event. We, of course, had good, very acute information on diagnostics and prevention of melanoma. We do hope that we will have this event on a regular basis more frequently, and we also want to see you both online and offline on a regular basis, and it would be our pleasure to invite you again and again. because there were a lot of useful information in this wonderful by you in this presentation. I'm sure it will be useful and helpful not only for practicing the dermatovenerologists or cosmetologists or oncologists, but it will be useful also for physicians, for our students of medical institutes. I wish you a solid health. I wish you good luck, and I do hope that there will be a next event where we will see you. As we would like to pass the word to the director of, to the chairman of the Association of Uzbekistan Oncology Association. Please, Mr. Tilla Shaykhov, feel free, the floor is yours. Of dear participants of our conference. Actually, I enjoy so much from taking part in this conference. And not only me, I guess, all of the oncologists, dermatologists, venerologists who attend this conference enjoyed, obviously, and for all of our participants, at least I think it was extremely useful, but I'm sure it was useful for all of our patients. They are the direct beneficiaries from our knowledge today. Of course, this melanoma is a very terrible pathology, unfortunately, and this is the most acute problem in oncology, and thus our conference was dedicated to this important issue. And once again, I would like to thank all of our participants for their fruitful, interesting, and meaningful content of presentation. And I do hope there will be a chances for us to meet again. And my wish to all of us that for all of us, I do hope that this situation with COVID will be resolved in our country. Of course, we had a good, favorable forecast for our country. We had probably 10 or 15 patients, COVID patients now, and we do hope that this disease will be defeated all over the world, and we will have a chance at least once a year, or at least once in 2 years, to have a chance biannually to meet each other face-to-face on such offline conferences now, and there will be useful reports, useful for our patients and both for our colleagues, for our oncologists, while early diagnostics of this disease. And again, on the behalf of our oncological center and our oncologists, I would like to thank our participants, Ms. Jamila and you, sir, for your participation. Thank you. I guess this is the end. Bye. See you and hope to see you soon.